Sure.
Assalamu alaikum. So we will start our free paper session. And in this session, so there are in total 3 judges. With me is Professor Sohail Qureshi. He is a Director of Research and Innovation at Shalimar Medical College. And Dr. Ahsan Bakar, he is an Associate Director and Consultant Anesthesia. And I am Muhammad Usman Rashid, working as Senior Research Scientist and Head of Basic Sciences. So our first speaker, so there are 10 minutes for each presentation, and the question answer would be at the end,
Yeah.
correct?
Yeah.
Yeah. So our first speaker is from Fatma Memorial Hospital College of Medicine and Dentistry, Mr. Ehsan Majid. He will talk about efficacy of intraoperative low-dose IV ketamine for acute postoperative pain control, meta-analysis of randomized controlled trials. Dr. Ehsan Majid. Miss Ehsan Majid. Irfana? Irfa. But here it's mentioned Ehsan. Okay, Irfa.
So the full name is Irfa Ahsan Majid, right?
Irfa Rafiq.
Okay.
Assalamu alaikum and hi everyone. My name is Irfa Rafiq. I'm a BA student at Fatma Memorial Medical and Dental College. Today, the study I'm going to present is meta-analysis of randomized controlled trial investigating efficacy of intra-operative low-dose esketamine for acute post-operative pain control. So let's begin with our topics. Firstly, talk about the background of our topic. In the background, first talk about what's acute postoperative pain. We are evaluating acute postoperative pain, which is one of the major concerns for first 2 days after the operation, and up to 80% report inadequate control. So it needs to be addressed, and the main things we use to control this is opioids. But why do we need something new and to add something to control this? Because opioids have serious side effects. Esketamine, an enantiomer of racemic ketamine, is an NMDA receptor antagonist of an analgesic, an opioid-sparing effect with minimal psychotomimetic side effects, especially at low dose. What does I mean by low dose? Is less than 1 mg per kg. So they have been done previous reviews, but their regimens were not homogeneous. Either they were giving intraoperative, postoperative analgesia, and the timing and the dose of esketamine wasn't specified. So evidence was inconsistent. So that's why we are doing the meta-analysis, so that we can use the use of esketamine provides an opportunity to enhance the anesthesia by anesthesia practice by introducing a well-known low-risk agent at sub-anesthetic dose that means reduce the acute postoperative pain, postoperative opioid consumption, and analgesic requirement. So now moving towards what was PICO of my study. The PICO of my study is P stands for population, which I included the patient undergoing surgery and included vast variety of surgeries. Intervention was intraoperative low-dose esketamine. Control was normal saline, and outcome, primary outcome is acute postoperative pain score. So we evaluated the studies on the basis of inclusion criteria. All the studies were RCTs, adults, patients were given general anesthesia, and esketamine dose was less than 1 mg per kg. We excluded study on the basis of this criteria, which included patient given regional spinal anesthesia, surgeries performing emergencies, and greater than 1 mg per kg dose, and esketamine was given in patient control analgesia. So moving towards the methods, the design of the study is systemic review and meta-analysis based on PRISMA and Cochrane guidelines. The databases we researched to identify the studies were from PubMed, Cochrane, Embase, and Scopus. We included the study from inception till April 2025. This is the PRISMA flow chart of our study. After identifying and evaluating the screening and evaluating the study, at the end, total studies that were included were 35. So coming towards the primary outcome, the main concern of our research was pain at rest and movement from 4 hours to 48 hours after surgery. Then this coming to a secondary outcome, they were adverse effect, opioid rescue, analgesic, and propofol consumption. So analysis, We done analysis by using R programming, mean difference risk ratio with 95% confidence interval, heterogeneity by I2 test, egress test, sensitivity analysis, and meta regression. So now moving forward with the results, first talk about, as I mentioned earlier, we include 35 RCTs, and total number of patients were 3,831, out of which 60% belong to esketamine group and 40% were belonging to the control group. So what were the surgical interventions we evaluated? We evaluated abdominal, thoracic, spinal, breast, thyroid, gynecological, and other surgical procedures. So risk of bias were assessed by using Cochrane risk of bias tool. 7 studies show higher risk, 16 show some concern. These were due to subjective nature of our outcome, acute pain, as well as due to observer bias. And then 12 show low risk. So now moving forward with the primary outcome, as I mentioned earlier, primary outcome is acute postoperative pain control at rest and movement, observing 4 to 48 hours. As you can see, this pain control at rest was significant and sustained analgesic benefit at rest. However, we observed that on movement, pain control wasn't significant, but wasn't sustained. It was less consistent. Why? Because variable factors come in this, that type of surgery performed, tissue trauma, as well as type of trauma, amount of trauma, or degree of trauma given during the surgery. Now coming towards the secondary outcomes. For the secondary outcomes, let's talk about first the adverse effect. We observed there was no significant difference between the adverse events between the intervention and control group, which is a very positive effect of our study. And then propofol use was decreased by up to 18 mg. Along with post-operative morphine consumption was decreased up to 19 mg till 48 hours. Then moving towards rescue analgesia, there was significant reduction in the rescue analgesia and dose response regression. We performed meta regression, and there was no statistically significant difference was seen in dose and response regression test. Then there was low risk of application bias done by using funnel chart symmetry as well as egress tests. Then the conclusion. So coming towards the conclusion of our study, let's intraoperative low dose IV esketamine less than 1 mg per kg significantly reduce acute postoperative pain, intraoperative analgesic requirement, and opioid consumption, along with no increase in adverse events. So why do we do this matter? Because we want a clinical implication of this. So what is the clinical implication? Esketamine is an effective opioid-sparing adjuvant for acute postoperative pain under procedure performed under general anesthesia, as well as supports the inclusion of esketamine within multimodal perioperative analgesic strategies. So do we have any questions?
Thank you very much, Ms. Irfa. So we'll have question answer at the end of the session.
Okay.
So if I can ask, so when you say the dose that you studied in your analysis was less than 1 milligram per kg.
Yes.
So less than 1 milligram per kg is still a fairly wide spectrum of dose. So how much? Is that 0.5, 0.8? Less than 1 milligram is still a very wide spectrum that you're looking at.
Actually, as we included multiple RCTs, 35 RCTs, so all of them weren't specifically saying that less than 1, but we included that it was less than 1 जो सब doses में आ रही थी, उन सब RCTs में less than 1 mg include हमने study की, as there was heterogeneous regimens and they weren't specifying the dose.
So do you think that is a limitation of your study, that there is no unified dose that you looked at?
Yes, but it's still less than 1 sub-anesthetic dose.
Right, okay, thank you.
Thank you so much.
Thank you.
Okay, our next presentation is the title. It's going to be by Syed Muhammad Hur Abbas. Are you here? Okay, and he's going to be talking about the enhancing efficiency in post-anesthesia care unit discharges, and it's a non-clinical audit perspective. Please. And he's from Shaukat Khanum Memorial Cancer in Peshawar. Yes.
Assalamu alaikum and good afternoon. My name is Dr. Syed Mohammad Hur Abbas, and I am the Chief Resident of Anesthesia and Pain Medicine Department at Shaukat Khanum, Peshawar, Peshawar. So the title of my presentation is Enhancing Efficiency in Post-Anesthesia Care Unit. So it's a non-clinical audit perspective. So as a background, so PACU is a unit where after the extubation, after the surgery or any procedure that needed sedation or anesthesia, so the patient is shifted to the PACU unit, and it provides continuous round-the-clock post-operative care. So some delayed discharges were observed, and which can lead to OR workflow disruption, as there are multiple cases going on daily basis. So if patients are delayed in their discharges from PACU to their desired department, like whether HDU, ICU, or inpatient department, or some day cases surgeries, so if there are delays in the discharges, so it can disrupt the workflow of the hospital. Also, it will contribute to the longer hospital stays and increased healthcare cost, of course. So both clinical and non-clinical factors can contribute to this delays. So the clinical factors are something that we need to address and we need to manage accordingly, whether it's laryngospasm after the extubation, or it's pain that the patient is complaining of, or any other complication that we can count off under the heading of clinical complications. So this is what we cannot minimize. We need to manage it no matter how long it takes. So the main purpose of this study was to focus on the non-clinical factors, which are very easily managed if the whole team is working in collaboration with each other. So the non-clinical factors were less studied. So some delays were even observed at SKM Peshawar for more than a day in PACU. The patient was there in PACU maybe because of the beds were not there or due to some other non-clinical reasons. So that was the reason that we initiated this audit. So audit initiated to identify and address non-clinical causes of PACU discharge. So the objective was to identify the non-clinical factors and implement the quality improvement strategies to reduce PACU length of stay for the patients. So in July 2023, new KPI was introduced, and which was set like after the post fitness of the patient, the PACU length of stay should be less than an hour. So retrospective data was collected from 69 patients in September 2023. So 2 PDSA cycles were also conducted. We will be discussing these interventions later on as well, but the major interventions that we did were educational sessions of the doctors and the nursing staff, along with audit team expansion that we did in the PDSA cycle 2. Monthly QA meetings were done, and staff busyness was tracked and documented. Also, logistic changes were also made, which is like added 2 HDU beds to the hospital. So the baseline findings were only 62 patients discharged were within the target time. Non-clinical causes were staff busyness, whether it was a shift change or porter delays, lunch breaks, or lack of HDU beds or ward beds as well. So the first PDSA cycle, October to November 2023. So departmental meeting and educational sessions were done. PACU staff began documenting the reasons that why the delays were there. So as a result, compliance was improved from 62 to 74%, but which was still below the set target, which was 95%. At PDSA cycle 2, which was from December to Feb 2024, December 2023 to Feb 2024, audit team was expanded. PACU nurse, registered nurse at level 3 and above, clinical nurse manager was also involved in the audit team. Monthly meetings were done, new data was collected, 2 HDU beds were also added during this time. So as a result, the target was achieved, 95% compliance by February 2024. So as we can see the trend of improvement, the baseline was 62%, then PDSA one cycle, it was 74%, after second cycle, it was 95%, and which was then maintained. So the major non-clinical factors were staff busyness and bed unavailabilities. Team-based communication and monthly review meetings enhanced the coordination. Infrastructure improvement, as I said, that extra 2 HDU beds were added. So that was important. So the discussion of this presentation is that we were mainly focusing on the non-clinical causes because they are equally impactful as the clinical causes. And as I said, that clinical causes we manage, and how long it takes So it depends upon the complication and the management as well. So the non-clinical causes are something that we can manage and which enhances this performance of the PACU length of stay. So dashboards and KPIs help track performance. Interdepartmental collaboration essential for sustainable improvement. So the conclusion of this study, which was conducted by our consultants, anesthetists at Peshawar, Dr. Faraz and other consultants as well. So this was that addressing non-clinical factors, staffing, logistics, bed management, and also regular QI meetings were done, and the communication sustained the progress of this PACU length of stay. Any questions?
Thank you very much. So based on this clinical audit or non-clinical audit, what implications or changes have been
Made.
made?
Okay. So in terms of this, like as I said, that the whole team was involved, whether it's anesthetists, doctors, the PACU nursing staff. So it was a team-based discussion where we first of all identified the causes that were causing the delays. Then we implemented the changes at how we can bring improvement in these. So that was increasing the staff and also adding the 2 HDU beds. So that was important because once the patient is fit for discharge, so it is like the patient is transferred to HDU or the inpatient department. So if the beds are available, if the staff is sufficient and there, and if the lunch breaks and these things are monitored and like discussed among the team members, and they are equally provided with the lunch breaks and all those time. So these things can improve these non-clinical factors as well.
Thank you very much.
Thank you so much.
Okay, so we continue. Our next talk is going to be delivered by Mr. Paras Javed. Where are you? Paras Javed from Khan University.
Is it online?
Sir, उनकी absent.
Okay.
Sir, absent है उनकी.
So the next one is by Mr. Noor Muhammad from Shaukat Khanum Hospital. That's you. He's going to be talking about the predominance of MGMT promoter methylation in Pakistani glioblastoma patients. Please.
So, Assalamu alaikum. Welcome, everybody. I'm going to talk about predominance of MGMT promoter methylation in Pakistani glioblastoma patients. And this study was performed at Basic Sciences Research Department of Shaukat Khanum Memorial Cancer Hospital and Research Center. So glioma are the leading primary brain malignancy, and glioblastoma multiforme is the most common subtype, accounting for 38% of all gliomas. In Pakistan, GBM predominantly affects younger individuals with median age at diagnosis of 45 years. Worldwide, GBM has median overall survival of up to 15 months, whereas the 5-year survival rate, it's very low, up to 7%. And overall survival of GBM patients in Pakistan is much worse, that is up to 14 months. And about 1/4 of the patients who were diagnosed with this disease, they have recurrence of the disease in the same year. So standard treatment for this glioblastoma is the surgery followed by radiotherapy and chemotherapy, that is temozolomide and alkylating agent. And temozolomide efficacy is challenged by O6-methylguanine DNA repair enzyme, that is MGMT. And here is the mechanism of how this temozolomide affect. It methylate the guanine at O6 position and convert into O6-methylguanine. And then when the methylguanine conformed, it initiate the apoptosis of the glioma cells. But the functional MGMT, it remove the methyl group and then it repair the methyl and then survival of the GBM cells. So if this MGMT is inhibited or it's non-functional, then this efficacy is increased. So inactivation of MGMT by promoter methylation is advantageous for temozolomide efficacy. MGMT promoter methylation vary by geographical distribution and ethnicity. Most of the studies have been conducted among Caucasian populations from Europe, USA, and Australia, and methylation frequency have been reported from 24% to 68%. Few studies from Asian, from China, Japan, Korea, and India reported 33% to 66% methylation frequency. However, no prior studies from Pakistan are reported. So we designed this study to analyze MGMT promoter methylation in Pakistani GBM patients and to assess the association of MGMT methylation with clinical pathological features and overall survival in glioblastoma patients. This study was approved by Institutional Review Board of Shaukat Khanum Memorial Cancer Hospital and Research Center. In total, 48 patients were included in this study in a period of 10 years. And eligibility criteria was primary GBM diagnosed at or above age 18 years, histopathologically confirmed GBM, and those patients with available formalin fixed paraffin embedded tumor tissues and having no prior chemotherapy or radiotherapy treatment. Clinical, pathological, and treatment and survival data were collected from hospital records. The tumor tissues were assessed for tumor contents for 2 independent histopathologists, and those tumors with more than 80% tumor contents, they were processed for DNA extraction. And after DNA extraction, the quality of DNA was assessed and working dilutions were prepared. Afterwards, 500 nanogram of DNA from each patient, it was bisulfite converted. What is bisulfite conversion? It converted cytosine to thiamine at CPG sites where there is no methylation of the cytosine. If cytosine is methylated, it remains unchanged. And then the detection of methylation was performed by methylation-specific PCR. And the methylation was called by fragment size. If fragment size is 81 base pair, it is unmethylated. And if it's 93 base pair on agarose gel, it's methylated. And 10% of the patients, DNA samples, these were randomly selected after methylation PCR, and they were sequenced to confirm the concordance of the methylation-specific PCR, and we found 100% concordance between methylation-specific PCR and Sanger sequencing. These are the DNA sequencing chromatogram. Panel A shows the methylated DNA fragments. You can see that all the Cs are there, C means cytosine. These are not converted into thiamine. Whereas in unmethylated, these cytosine are converted into thiamine, and you can see there is no cytosine in the sequencing chromatogram. And MGMT methylation was detected in 87.5% of all GBM patients. These are the clinical pathological features. There were no significant difference in methylated versus unmethylated patients regarding all the clinical pathological features. These are the prognostic factors for overall survival for those patients with methylated MGMT, 42 patients, and age at diagnosis and treatment modalities. These were 2 prognostic factors for overall survival, whereas the gender, WHO performance status, treatment modality, MGMT gene methylation, these were not associated with overall survival. So regarding the age at diagnosis, those patients who were diagnosed at above age 50, they have median overall survival of 4.8 months compared to those diagnosed below 50. These were 9.1 months. And this difference was significant. And the patients treated with surgery only, they have median overall survival of 2.2 months. And those who were treated with surgery and radiotherapy, they have 7.2 months median overall survival. And those who were treated with radiotherapy followed by chemotherapy, they have longer overall survival, 16.9 months. And this difference was statistically significant from those patients which were treated only having surgery. So our study have some limitations. It's a retrospective study. Single institutional design limits the generalizability of the results. And we also not performed progression-free survival because the MRI reports for disease progression were not available from the patients. And we analyzed the methylation using methylation-specific PCR. This is a qualitative analysis, and we did not perform quantitative analysis of methylation at individual sites. So in conclusion, this is the first study from Pakistan that reported high prevalence of MGMT promoter methylation in Pakistani GBM patients. And the glioblastoma patients who were treated with surgery followed by chemoradiotherapy and having MGMT methylation, they had significantly improved overall survival. So we are thankful to the study participants, study team, including Dr. Bilal Malik, Research Associate, Dr. Sameer Fasi, Consultant Medical Oncologist, Dr. Shahid Hamid, Consultant Neurosurgeon, and Dr. Asif Loya, Consultant Pathologist. And this study was supervised by Dr. Muhammad Usman Rashid. And this study was published in high impact journal Molecular Biology Reports. Thank you very much. Any questions?
Any questions? I have a quick question for you.
Yeah.
I think in the second, third slide, you mentioned ranges of MGMT promoter methylation to studies. Some of those ranges were quite significant, from like 28 to 65%.
Yeah.
I'm just wondering, okay, maybe one limitation in your study is that you're using methylation specific PCR as compared to an open-minded kind of a thing. You do the conversion, PCR amplify, you sequence.
Yeah.
That would be an open-minded way. So I'm thinking that maybe those ranges are because people are using different ways of different methods. One would be, जो आप इस्तेमाल कर रहे हो, and the other one would be in kind of a whole promoter conversion followed by sequencing. So you can sort of figure out okay, which of those CPGs are methylators.
Yeah, in the studies, different methodologies have been used. Some use methylation specific PCR as we have performed. Some of the studies, they have performed high resolution melting analysis. And few studies, they have performed quantitative analysis, that is pyrosequencing. And pyrosequencing is more sensitive as compared to these conventional technologies. But these conventional technologies, these are qualitative, and they tell us how much samples they have been methylation. Yeah, thank you.
So, Dr. Noor, how do you compare the results of your study with the internationally published data?
So
because my understanding was that doing surgery, radiation, and chemotherapy was standard treatment for gliomas.
Yeah. Yes, regarding treatment, this is the standard treatment of a glioblastoma. But in international other studies, they have also reported the similar results. When a patient, glioblastoma patient, has MGMT methylated, then treated with temozolomide, it improves the survival. This is an international standard. Now, MGMT, it's in molecular testing, it's recommended for all glioblastoma patients to be tested for MGMT methylation before performing further treatments.
Okay, thank you.
Yeah. Thank you.
Thank you. So our next speaker is Dr. Aliza Mirza from Minhaj University. She will talk about HLA class 1 polymorphisms among the Punjabi population of Pakistan and a comparative analysis with countries' other ethnic groups.
Assalamu alaikum. First of all, I would like to welcome all of you at Shaukat Khanum Cancer Symposium 2025, held by Shaukat Khanum Hospital, Lahore. Basically, I am medical technologist from Shaukat Khanum Hospital, Lahore, but the study I conducted was from Minhaj University. And today I would like to present my research publication on HLA class 1 polymorphism among the Punjabi population of Pakistan. So basically, we do conduct a study on HLA class 1 polymorphisms among the Punjabi population and then compare them with the other ethnic groups present in our country, basically the Sindhi population, Baloch, Pathan, Bravi, Brusho, and Kalash, something more like that. So basically, what is HLA? HLA stands for human leukocytes antigen. Basically, these are the human version of MHC molecules, and we all know that MHC molecules are key immune receptors in all body receptors. They are present on all nucleated cells of our body and they present antigenic peptides for cellular differentiation. And this is the basic principle of immune system. And there's the all immune system goes on. So basically, this is the genetics of HLA molecules. These are present on the nucleated cells of our body except RBCs. Okay? There are two types of HLA molecules, class 1 and class 2. There is some sort of class 3 type, but it is not that much interesting. Chromosome 6p21.3 की position पर we have HLA molecules and we study HLA class 1 molecules as well. So the basic thing is that why HLA class 1 polymorphism matters. Class 1 polymorphism matters that it is the highly variable genomic loci of our human system. Most loci linked, these are thousands and multiples of disease that had been linked to HLA molecules. And this is the one of the most polymorphic loci that I've identified immune responses, cancers, autoimmune diseases, and infectious diseases as well. The major clinical feature of this study was two relevance transplantation studies. As we all know that the transplantation is very critical for stem cells, blood grouping, as well as organ transplantations. So compatibility testing among HLA molecules is an important factor. As well as the anthropological studies also shows that HLA molecules have been linked to very population-specific areas. So ancestry and migration patterns can be identified by that. So in this study, we conducted a HLA class 1 study among the Punjabi population. There was a very huge data available for the Pakistani ethnic groups, including population of Pathan, Sindhi, Balochi, Bravi, Brushos, and Kalash as well. But there was no any data for Punjabi population of Pakistan, which is the largest ethnic group as well. So in this study, we identified HLA class 1 types, HLA A, B, C, allele and haplotypes in the Punjabi population of Pakistan. We then compare them with Indian Punjabis and Pakistani other ethnic groups as well, and assess the genetic affinities and evolutionary patterns among them. So in this study, basically 389 Punjabi subjects were included. HLA typing of these individuals were conducted by PCR SSO Luminix method, and the 3 loci were typed at 2 field resolution. Statistical analysis included Hardy-Weinberg equilibrium analysis, linkage disequilibrium analysis, multidimensional scaling of their alleles, and neighbor joining analysis of phylogenetic tree. For comparison, the data were retrieved from the AFND database, which is population-specific for HLA genes. So, what do we find in our study? In our study, we identified class 162 class 1 alleles. Among them, 41 were HLA-A, 72 were HLA-B, and 49 were HLA-C. So you can see that how diverse the HLA polymorphisms are in our Pakistani population as well in Punjabi population. And the number of total haplotypes we identified were 522. So these are the major results of our study. Top HLA class 1 serologies and their alleles and their haplotypes. So what we identified was that the HLA-B loci was most diverse and most heterogenic loci of Punjabi population as compared to A and then C. Hardy-Weinberg equilibrium identified that locus B showed deviation, but the Evans-Watterson neutrality testing did not support this conclusion. So we can say that endogamy and inter-caste marriages can affect these results. As well as we also identified linkage district LD analysis of our loci, and all the haplotypes were in linkage disequilibrium. So the Pakistani Punjabis and Indian Punjabis, what was the difference? There was no as such main difference identified. However, we do identify some common alleles. HLA-A11, B35, 40, C4, and C7 were all common among Punjabi population. It shows that they shared ancestry from their background. However, we do also identified some differences. For example, it was also seen that unique alleles were found. In HLA, in Indian Punjabis, there was a 9 that was unique to them, which were not present in Pakistani Punjabis, as well as B51 that was not present in Indian Punjabis. So we can say that these differences would like to arise from religious endogamy practices or post-partition demographic shifts that had been identified after partition 1947. During comparison with other Pakistani ethnic groups, which included Punjabi, Sindhi, Baloch, and Kalash, we identified a total of 76 HLA class 1 alleles among Pakistani populations. And among them, the highest polymorphism was identified in Punjabi population, which was 66 overall allele count, that is more than enough for many of the populations. These are the also values for other groups, but that are not that much intense. So each group showed its own distinctivity. HLA types were identified, prevalent types were identified in all groups, and unique types. It was also seen that most of the alleles were unique in all groups, and finding compatible donor for that HLA type for blood grouping is very critical. And we can identify by this data that how could we find incompatible donor for any study. So the major interesting thing of our study was phylogenetic analysis, that how the populations of our Pakistan anthropological related to each other. It was interesting to see that geography, history, and many other factors, like you can say language, played a complex role in that. Punjabi and Sindhi, as we know that they share geography, they share common languages, and some sort of Indus Valley civilization history, they collapsed together. So Punjabi and Sindhi were more similar to each other. Baloch and Brahui were similar to each other as they all residing in the Balochistan areas. And Pathan and Kalash were more similar to each other because they resides in the northern areas of Pakistan. So what were the key findings of our study? It was seen that positive selection pressure was identified at HLA-B locus, and which was highly diverse, or all other genes were highly diverse. Other than that, Y chromosome studies previously studied SNPs and STRs almost showed same result as compared to our HLA study. So it is confirmed by different studies previously done on anthropologically that our study findings are matched with anthropology and their genetics. So how do we interpret our study? We do interpret that most of the Pakistani groups shared same ancestry with regional differentiations. However, population structure was more affected by language, geography, and migration patterns done in history. So how could we implicate our study? First of all, transplantation medicine, it is the major critical issue that finding a compatible donor for example, when a person has HLA type A and you could not find a compatible donor alongside, then you can identify from this study that where is donor and how could you find them. Other than that, we have disease association studies. We can identify most of the alleles that are linked to a disease. As we know that more of 100 diseases that are linked to HLA molecules. So we can identify which diseases has been linked to which molecules and how could we tackle them. So that's why which can help in personalized medicine to identify what group would need what person. Most of the interesting topic was anthropological insights that were very critical and initial interesting for as well. So the data is available at HLA's website, AFND, reference number mentioned there. You can access there, and all of the data are present there. You can find a compatible donor where there. Thank you.
Thank you very much. So, Ms. Eliza, please mention how did you recruit your study participants?
It was a difficult task as well. However, we do collaborate with some private labs that give us data. Basically, my research supervisor helped to gather this data and conducted study on that.
So, what was the cost of those 300 plus patients or individuals from Punjab? Because there are several pockets. So, not Punjabi living in Sialkot does not have the same structure, genetic structure as somebody living in, for example, in Lahore. So, have you checked the caste of those Punjabi individuals recruited in your study?
Yes, we considered that, but that was not possible because Punjabi population is much more diverse than caste. There are caste subgroups and their subgroups. One of the previous study had identified Gujar group, and we also included in our study, but due to time limitation, we do not add them there. We do consider it, but in discussion section of our research, we do mention it.
So secondly, how did you perform haplotype analysis?
Yeah, it was a difficult task.
From which assay you have performed this?
Basically, we do type HLA class 1, which gives us haplotype analysis of whole. For example, for an individual person, we do haplotype analysis for allele 1 and allele 2, and then combine them with match IT software, which is the HLA specific software, and it gives him haplotype.
Which technique have you used?
For haplotype?
Yes,
Yeah, I don't know the technique, but match IT software had its own.
thank you.
For this project? Where did you get funding from this project? Sorry, one last question. Sorry. This is a very exciting project, but I think I'll build on the same theme as Usman has suggested.
It's the first
Punjabi itself is a very heterogeneous group. You can't really call it a homogeneous group because I expect somebody living in Rajapoon is very different from somebody living in Kahuta. So two questions here.
Yeah, you can.
Homogeneity versus heterogeneity and funding, please.
Unfortunately, we did not get any funding. Basically, that's why my supervisor, which collected the data from a private lab, and without university's consent and through their approval, it was done. So I think our university would then have something, but I don't know that because it was done by my supervisor. And heterogeneity, next question, please.
Homogeneity versus heterogeneity, because Punjab population itself is not homogeneous, it is heterogeneous, I would like to believe.
At first, we identified groups and castes, we divided them. But it was very critical to identify because mother is from that side, father is from that side, and intercaste marriages that affect too much that we could not contribute to this factor.
Okay, our last talk for this session is going to be by Miss Beenish Hayat. She's at SIMS. Beenish, where are you? She's not here. Beenish, where are you? Looks like she's not here. Okay.
So is there any question from the audience for any speaker before we conclude the session? It seems there is no more questions, so then we'll conclude the session. So we thank the speakers for their contribution, for the excellent work they have presented here. Thank you very much.